Good morning, ladies and gentlemen. Once again, as I've already told you, you will see the text in English on the screen while I'll be speaking Polish. So now we are moving to the field of clinical aspects. I would like to remind you at a very general level of techniques and technologies used in interventional radiology, and from the point of view of medical doctors, physicists, that's the knowledge that is all professionals. It's the knowledge that is important to all of us. So interventional radiology is a subspecialty of radiology. I'm not sure whether it's really minimally invasive, but we are speaking of the intervention. So after all, these are aspects that may lead to unwanted effects, but today we focus on radiological safety. There are many procedures of interventional radiology that are performed using X-ray, fluoro, DSA, angiography, but also, well, computed tomography with fluoroscopy. Interventional radiologists are less involved in this, but there are procedures such as ablations. I've already told you that we have many procedures that are not radiation guided, but for example, ultrasonography also comes into this stage. Well, the first publications appeared 30 years ago when IRPA published their important information for physicians and other healthcare professionals, which addressed the problem of cautious approach to exams using X-ray because of skin injuries, especially during fluoroscopically guided procedures. In 1996, International Congress of Radiation Protection in Vienna, that was the first report speaking about the consequences of fluoroscopy in interventional radiology. Well, that related mainly to skin injuries. This induced changes not only refer to skin, although the skin injuries are the best tested. The director mentioned scattered radiation, that is radiation scattered from the patient. Well, the patient is the main source of radiation to the staff. So we must remember about scattered radiation. So, well, my presentation is more clinical. I'll be telling you mainly about more or less spectacular effects of therapy, and I will try and explain to you why this therapy is so important and why we should practice it. So what should we know about interventional radiology? Interventional radiology offers a wide range of procedures that are definitely less invasive than surgery, often more effective, and sometimes they transfer this burden and frequency of procedures into interventional radiology from classical surgery procedures. Although there are non-vascular procedures Interventional radiology can be divided into vascular, endovascular, and non-vascular procedures, such as ablations or other techniques of drug administration. So these are all these vascular applications of interventional radiology. Neuroradiology, you can see arteriosclerosis, arterial recanalization, disinsection treatment. This is a very big group of pathologies where there are in the body of the organ that lead to bleedings. So neuroradiology is mainly about counteracting bleedings when we cannot embolize the effects of bleedings. Well, also urology, for example, is another field. As you know, renal tumors. That's very important. At the bottom of this slide, you can see interventional oncology. These are palliative treatment techniques for treating tumors and venous interventions. These are very difficult procedures. All these pathologies that result from them, all kinds of malformations make a very difficult area. Where this is the equipment, the tools that we use. This is for those of you who are not physicians. Needle, introductor, catheters, and wires, which allow us to, the catheters are sometimes very, very thin, very selective for procedures performed in the brain, where we introduce balloon, or this is our bread and butter for interventional radiologists. And these are vascular access sites through femoral artery or cortoid or radial. That's the arterial access on the left-hand side. Both are quite difficult. So, not mentioning complications, sometimes mechanical injuries. So it's not so easy and rosy. So these are access points, femoral access, cartoid, direct cartoid puncture, or radial access. So here you can see images from our everyday practice. They are quite impressive, especially in 3D reconstructions. Most multiplanary reconstruction angiographs, they registered images, as you can see. So this aneurysm that you can see, it's after the closure, and vascular reconstruction on the right-hand side. This is the reconstructed DSA image from angiography. Well, doses are quite high. They are not in one DSA angiography. This is a sequential angiograph. We take this catheter and we administer coil small springs. Do I have a pointer? I don't want. I wouldn't like to deprive you of the image. Okay, so yeah. Can you see that all? Well, it's just okay. I'll be using it. So it's after the embolization, and here we can see something that besides cardiovascular causes of death, these are strokes, brain strokes. I think we should focus on it a little bit more, because this is the treatment. These procedures we perform them on an everyday basis, and they are life-saving procedures. We prevent brain strokes. You can see here after the removal. And AVM treatment on the right-hand side. But stroke treatment today, this is the most critical, the most important part of interventional neuroradiology. And these three procedures that I mentioned, embolization, where we administer diverse chemical compounds which produce what you can see on the right-hand side, onyx. These are embolizing products or procedures. This is the coil embolization on the right-hand side, and in the middle, stroke thrombectomy, where we remove the clot from the vein. This is these are the procedures that we are performing every day. It's also important that thanks to this modern multi-planar equipment for DSA and geography, you can see the image where we can decide what technique will be applied where. And we also make assessments in computed tomography, where the exposure is bigger to the patient than to the staff. In perfusion, we can see the assessment of the area where heart attack, for example, may take place. So this is, we use either interventional radiology, or we use radiology to assist us in making diagnosis. So arteriosclerosis treatment, well, arterial recanalization, or things like renal artery stenosis, visceral artery stenosis, peripheral arterial diseases. And these are procedures, well, carotid stenosis and peripheral arterial disease, we apply stents. And this is a one-day procedure, practically. A patient comes in the morning, the procedure takes place, and he or she leaves in the evening. And that also saves money to, well, the procedure which used to take many hours, or of course we can also treat heart defects in this way. I will show you that. So, for example, carotid artery stenting, distal protection devices are devices which, well, before we apply stent to the carotid artery, so a patient who may suffer stroke in a moment we apply different devices which prevent the vein from, or the artery from being blocked, from being clogged. And above you can see these protective devices. Well, I'm showing that to you just to show you that it's all part of angiography. It's not that we apply catheter and that's all. It's a very complex and justified procedure which prevents these clogs from getting to the brain. And these are our images. This is carotid artery stenosis treated with stents. You can see this part on the left hand side, this narrowed, well, practically we see only the outer area, and we apply stents. And another patient with stroke symptoms. This is angio-CT, which shows occlusion of carotid artery, and here we can see the dissection of subocclusion dissection, which is quite critical because that led to the symptoms of stroke. Subocclusion, very thin, and what we do, well, we apply these devices. We introduce catheter, and then stent, and the artery looks better than before. So it looks almost ideal after the implementation of stent. 10 days after this TIAEA, TIAEA, which is kind of mini stroke, which hasn't taken place, but which shows that there is something wrong with arteries. So we have subclavian artery stenosis, where the so-called Still syndrome develops. This is the narrow subclavian artery part, and blood gets away from brain, and it is directed to subclavian artery stenosis, subclavian artery. And what can interventional radiology do? We can apply catheter and a stent on the right hand side, and we get an appropriate diameter of the artery so the blood circulates normally without this stealing, and other areas.
So stenosis of the renal artery, hypoplasia, sclerosis like changes occur. You can see it when you look at the aorta, and again the stent has been introduced. It's very important clinically because these stenosis result in a high arterial pressure. Here you can see the implantation of the stent. First you have to have the balloon angioplasty, so you need to introduce the stent to make the vessel patent. Therapeutic effect is achieved. A very important group of therapies. This is a very important slide. It's about introducing balloons, catheters catheters which provide this extension. They are very important for the purpose of therapy to recanalize TB artery. This is a tibia artery, so the peripheral vessels are extended by using the balloon, and this problem is caused by the diabetes. So here you can see a patient with diabetes before treatment and 3 months after the treatment using the balloon. So arteries have been provided with the stents, and you can see a therapeutic effect. So here you can see a scar left after the healing process. Some changes at the level of great vessels. Here I mainly mean the aneurysms of aorta. This is one of the major risks to life. So in our work, we always, when we worked during duties, telephone or stationary duties, if we diagnose aneurysm, if there are some major pains, so we stent such vessels, but this procedure has to be done very quickly. The risk factor, mortality factor, very much depends on the time of implantation of the stent. So here you can see the grafts used in these kinds of aneurysms and stenosa. Here you can see some treatment for some sclerosis treatment. This is a case of occluding aneurysm in the spleen artery. So here we are using some special stents. This is a little bit different area from the areas I have been presenting before. So before the treatment, it's the picture on the left, and after the treatment, the picture on the right, after the stent has been introduced. A very interesting case and important one. You can see the application of our techniques in a very different, very specific cyst in the right kidney. So a vessel was reconstructed, CT exam was used. So we have noted big reservoirs filled with blood. So we knew that they were vascular changes. We had to use the occlusion, and these are some CT scans. So you can see the filling of these major changes, and this is the late phase when the blood is outflowing. And the procedure of introducing catheter, and then we were closing this malformation with coils. So here you can see the specific stages of introduction of the catheter, and then closing the lumen of this malformation with the coil. So here you can see this effect. So these are the coils introduced, and they closed this huge channel. So these are the correct vessels, and you can see how that area looked before the treatment and after. Another group, retroperitoneal bleeding after partial nephrectomy. Usually these procedures are used for minor tumors in kidneys. So some wedge technology has been used. So that was the bleeding we had to control. So this is the surgery that takes less than an hour. So it involved occlusion. So here you can see another problem. This part that has bled, has been bleeding. This part was supplied. Here you can see two kidney arteries. You can see the bleeding. Then a fragment of the kidney had to be removed. We introduced catheter into this space, but the bleeding continued, and the CT scan provided us with the diagnosis. It is very interesting in terms of anatomy. So using CT scan, actually we extended the procedure, but we knew that we had to occlude the lumen of this kidney, and we did it. So here you can see the coils and particles of a preparation that led to embolization. I'm just about to complete my presentation. Here you can see lots of different uses. For example, for the patient with the bleeding of hemangioma. You can see some abdominal arteries. You can see the treatment using coils to embolize the hemangioma. On the right-hand side, you can see the bleeding. Here you can see that the coil was inserted and it controlled the bleeding. Massive bleeding in the jaw artery. So you can see some malformation. This is the area of head, so lots of vascular malformation are diagnosed in this part of the body. So we are using small particles, acrylic preparations that occlude the lumen of malformations. We also use different types of glues. Here you can see the example of a large underknee aneurysm. It resulted from the gunshot wound. So a change developed, the wound was bleeding and the aneurysm had to be embolized. So we were using microcatheters and coils with in the specific size. Embolization of tumors. This is a new area. Vascular interventional radiology is used increasingly, and the techniques of ablations in this respect are also important for oncology, because if we have some lesions, oncological lesions or neurological lesions are related with the high vascularization anatomy of such parts. So interventional radiology is often now used by oncologists. Here I'm presenting some papers on the options provided by arterial embolization, embolization of symptomatic and asymptomatic renal angiomyolipomas. So embolization of arteries is used for the purpose of oncology. Here you can see a huge change. The central and lower part of the kidney are filled with huge tumor. Here you could see embolization. Here you can see the inside of the kidney. The tumor was bleeding, and after the treatment it was excluded from circulation. Treatment of liver tumor, so the same principle is applied. We are identifying the focus. You can see the SIRT acronym, so isotopes are administered into the tumor. So this is an additional so this is a very important field in radiological therapy. So small radiation is used, however, it is sufficient to damage tumors. So we have heard, we have the findings that the patient's survival rate is very high. So SIRT is one of the methods of administration of isotopes. Then the catheters have to be inserted into the vessels. This is an example of the selective intra-arterial radiotherapy using IP90 radiopharmaceutical used in this kind of therapies. Vein compression syndrome. Okay, I am coming to the end. I have prepared too many slides. Venous embolizations. In the case of malformation, here you can see the pelvic congestion syndrome. So you can see some pathologies. So it's not for the oncologist or surgeon, but it's for the interventional radiologist who is responsible for closing, occluding such malformations to provide the effective treatment and non-vascular interventions. That is the interventions applied for different pathologies of, for example, the spine. Let's start with the spine. It's interesting to all of us. Most of us are affected by such problems. So it is used in patients with advanced osteoporosis, or when there are this is the vertebroplasty treatment. So cement is introduced. It reconstructs, or it rather stops the compression of the fracture. Which leads to internal damages. Some nerves can be also damaged. So these procedures are performed by radiologists, also by neurosurgeons and orthopedic surgeons. So spine intervention, this is something I wanted to mention. And this is the Klachkin tumor. So in this procedure, we implant a stent in a biliary tract. Okay, we are missing a slide with TIPSs. So this is a percutaneous puncture of the biliary tract in the patients with liver hepatic tumor. And you can see the result after the procedure. So you can see that this huge widening of the biliary tract is removed. The compression has been removed. And you can see that now the tract is patent. To sum up, I would like to say that interventional radiology, from the perspective of the therapy, it's a benefit to the patients. The procedures are shorter. Very often they lead to radical improvement. I have mentioned such problems as changes in the brain arteries, great applications in the field of oncology. This interventional radiology actually requires to provide very precise radiological safety, so good quality equipment has to be used, good detailed measurements have to be taken. So if we follow the procedures, we will be able to improve the protection. It's also very important for patients who receive very high radiation doses. So trained and well qualified personnel is of key importance. So Professor, thank you for very detailed presentation, for telling us about majority of applications of the interventional radiology procedures used to save patients' lives and health. Your presentation stresses the fact that without the interventional radiology, we will not be able to have modern medicine. Professor, you have presented some relations between nuclear medicine and radiology and interventional radiology to treat tumors. I think this is unique, a very special change in the approach to nuclear medicine treatment. So first, when we are talking about nuclear medicine, we talk about administering radiopharmaceuticals that are absorbed by most part of the body. Here you are administering, you're providing treatment directly in the tumor. Yes, I think this is really amazing. Secondly, I have really noticed in your presentation, this is something which is inherent for the interventional radiology treatment. Well, it's about the distance you are looking at when you are actually performing your procedures. So this is a very precise treatment. So it's very impressive how precise the treatment can be. Are there any questions? Are there any questions or comments? Professor, I understand that there is no anatomic area where interventional radiology would not be able to be used. It's possible to treat any diseases. It's not only about neurological or venous problems. You started with the brain, and I think you also mentioned the diabetic food. Whenever we treat pathology or some vascular changes that of course are interrelated with pathologies, vertebroplasty example I have demonstrated, as osteoporosis. So no endovascular treatment is used, but we are just repairing the structure. Oncology, it's angiogenesis. It's a pathology of vessels. So tumor contains pathological vessels, so we need to occlude them. Of course, pharmaceuticals are also used to control angiogenesis. So we starve the tumor, we deprive it of oxygen, of blood, so it cannot develop.
I have a question. In all the countries, I suppose in Poland as well, interventional procedures are performed not by only radiologists, by many other professionals. What is the situation in Poland? I'm just curious.
Similar
to other
similar,
countries.
absolutely.
Yeah.
It depends on the region and personal preferences. It means if, for example, if a surgeon, vascular surgeon, wants to do angioplasty and angio intervention, is welcome. Yeah, we are working together.
But radiologists are always available, or for example, cardiologists or vascular surgeons can perform procedures by themselves without radiologists?
Sometimes in teams.
In teams.
Yeah.
Thank you.
Thank you very much. Any more questions, comments? Audience online?
How many procedures are performed by an experienced interventional radiologist? Well, how many? A week? Annually? Well, I work in a big hospital. Dr. Zawadzki will also be speaking about it. We have some angiography devices. Well, a week we perform several dozen procedures, from neuro to vessels. But referring to the question asked by Madame Vasilieva, interventional radiologists together with vascular surgeons do it. But when it comes to neuro procedures, rarely, very rarely, brain aneurysm is treated by a surgeon. Most aneurysm cases are treated as with coiling, and this is a procedure which offers much lower risk to the life of patient. So we just perform many procedures. And also types of these procedures. Well, it's a long list. Those that we do most frequently is embolization, different balloon procedures, coiling procedures, thrombectomy, renal peripheral stenting, but also AVMs, important because of the implications. I think that what the director said and what Director Vasilieva mentioned, well, to most regions where we can get vascular access, we can perform the procedure because it's mostly embolization, depending on the pathology. But I would have to make a long list of organs and procedures. So the answer to the question is a lot. Is it a satisfactory answer to the question? If yes, do we have any other questions? If not, I'd like to thank you, Professor Walecki, for this very enlightening introduction to interventional radiology in medical practice. I'm really impressed, but it also means that we will have a lot of work in our project. Well, this is also a huge challenge.